Welcome to Golden Hour Health and Safety, where we discuss pre-hospital information geared towards EMRs, EMTs, and paramedics of different levels. Today, we're going to be introducing our scenario checklist for you. Now, this is an integrated scenario checklist that talks about both medical and trauma at the same time. However, in a lot of schools, they tend to separate them to just a medical scenario and just a trauma scenario. If you'd like a copy of the scenario checklist, we do have that as well. We did break this down into sections. So this first section that we're going to be talking about is our scene size up. And if you do have a copy of our scenario checklist, you can follow along with that checklist, and that can certainly help you out. A quick disclaimer before we begin. This is for information only, and this does not replace your local training, protocols, new information, or research, and is not intended for those not working in, towards, or involved in healthcare. Please always follow your local protocol as well as your own scope of practice. So every scenario and every situation, even in real life, the first thing that you should always do when approaching a scene is what we call a scene size up. And it typically includes the following. Do you see, smell, hear, or notice any hazards? Put on your appropriate BSI or PPE. What is the date, time, and weather? How many people are involved, and do you need triage? What backup or support do I need for the situation? Are there any bystanders, and do they have any information? What is the chief complaint for the patient, and what is the mechanism of injury or nature of illness? So when driving up to the scene, I encourage you and your partner to talk it out loud. What do you see as you're approaching the scene? A few things that we are certainly looking for are fire, wire, gas, glass, traffic, people, weapons, drugs, and weather. We are also looking for and feeling for the emotion of the scene, which we often don't hear of when learning in emergency medicine. So are people panicked, calm, crying, yelling, screaming, silent? What is the energy in that situation, and what is actually happening with those emotions? Most hazards that we find in emergency services when responding are quite honestly a lot of times just things that we need to take note of, and we're not actually going to have to worry about. So if you find hazards, depending on the hazard, it could be something to take note of, be careful of, or something you may need support or backup to help you deal with. For example, glass on the ground is something to take note of, and it could give you some clues to the injuries of your patient. People who are visibly upset could be something we are careful of, and we're going to watch that mindset to see if they're going to change into a violent person on scene. That could be a new hazard to us. Or it could be that there's just some extreme weather and you need to protect yourself with extra layers before approaching, or extra PPE for severe respiratory conditions. Either way, we want to assess those hazards ahead of time. There are hazards that if you're not trained appropriately for and have the team to support you, you really should not enter. For example, a violent person on scene who appears and or has been reported being aggressive, hostile, or otherwise, you should really call for police support. Or another example would be if a house is on fire or a tanker truck is turned over in the ditch and there's gas everywhere, we should really be calling the fire department support for this. Remember, our goal is to go home at the end of the day, and risking yourself for your patient is really not part of our job. We really need to make sure we protect ourselves first and foremost so that we can continue helping patients in the future. Once you've decided what level of hazard the situation is going to have, we always want to put on our BSI, or some places call it PPE. So BSI is our body substance isolation, and our PPE is personal protective equipment. We use both terms here, as different services and institutions use both or one or the other. Most commonly though, I found that PPE is definitely the most common. Now the BSI and PPE that you may have access to wildly differs from place to place, service to service, and province to province. Plus, in emergency services, you need to decide what PPE or BSI is appropriate for the call, as you are the one walking into the unknown. So try to think ahead. Think of what the dispatch is telling you, and even if you get into the situation and you require extra PPE, go ahead and protect yourself first. Because again, you can't continue to offer emergency services help if you're putting yourself at risk or you get injured, you get sick, you get ill, you can contact anything that the patient might have. So just make sure that you're treating yourself and your colleagues as number one. When we talk about thinking ahead and thinking of ourselves as number one, always wear gloves. And we always suggest safety glasses. I have been that person in emergency services that wore safety glasses right from day one all the way up till now. And I highly encourage that. Now, this was recorded and written in 2022, so we have seen an active change in what minimum PPE is now, which also includes the use of a face mask. Will this go away in our future in emergency services? Like personally speaking, probably not. And in hindsight, in fairness, we probably should have been wearing them this whole time. As we're going into the unknown, we're going into people's homes with respiratory distresses, and we haven't typically, in my experience, been wearing, PPE in regards to face masks, safety glasses, and gloves all the time. So I do think that that mindset is changing. And just make sure that if you are going into, resuscitative efforts and things like that, that there is extra PPE like N95s, masks, face shields, etc., that you might consider to apply. But again, it takes you to take that call into mind before you actually go in and respond. Next, we want to tackle our date, time, and weather. This might seem silly, but there's a ton of information that you can gather for scene details, like the date, is it winter, spring, summer, fall? What are the common conditions in these seasons? Time, is it morning rush hour? Is it night out in the country where there's lots of wildlife? Is it evening supper time with the family? And the time you respond versus the time that the incident happens, and these things matter. Weather, is it windy, cold, icy, snowing, blizzard, hot? These all matter to the call, the patient, and to your assessments. So make sure you take note of those. The next thing we need to do is determine how many patients we have. Triage begins when you have more patients than your resources can handle. This could be a 3-person MVC with only one ambulance and all 3 are critical. I mean, we're going to talk more about that in a different lesson in regards to triage and what that represents, so don't stress about that right now. But you want to look at how many you have. Should you have more people than you actually found? For example, are there empty car seats? Could there be missing children in this incident? I once responded to an MVC with a motorcycle that was involved, and we ended up finding 2 sets of helmets, 2 sets of boots, 2 sets of jackets, and we only found one person. So we ended up having to search the ditches and search the scene extensively to see if there was a second person involved. Turns out it was just spare equipment that this person had with him, but at the end of the day, we still did our due diligence to absolutely comb the area to confirm that there wasn't an extra patient that we might have been missing. As I said before, call back up early. We can't stress this enough. If you are on your way and you think you need resources, get them rolling. If you arrive and you do your hazard check and you think you need them, call them now. If you approach the scene and you think, I need backup, do that now. If you're in the scene and you're in over your head, need help or whatever, call for extra hands early. It is always safer and easier to stand back up down if it turns out you don't need them than trying to get it afterwards and waiting for those resources to get to you. So backup and support also comes in a lot of different shapes and sizes. For example, this might be basic life support versus advanced life support, police services, fire department, hazmat control, fixed wing or rotor wing air support, city or town services like electrical, water, sewer, fish and wildlife, park officers, search and rescuers. Some of these services need time to prepare, so think ahead. I worked very close to a national park for quite a few years, and we found that if we did need fish and wildlife or search and rescue to help us find people who are lost in the woods, that it took an extreme amount of time to collect all those resources and get the appropriate equipment, whether that be boats or quads or snowmobiles to go and get these folks. So just think ahead. I've said it before, I'm going to say it again. Call ahead because you can always stand them down. Now, bystanders can be incredibly helpful. but they can also be incredibly dangerous and cause a hindrance to your patient care and your safety. So evaluate each individually and use or remove them from the scene as you need to. Visors can help with many things, so question them as well. For example, when the incident occurred, for how long, has this ever happened before? They can maybe help out with patient history, family, background, allergies, and a lot more. So you can include or not include visors as it helps the situation and helps the patient. The initial chief complaint here is typically the information that you received from dispatch as you're responding to the call, as well as asking those on scene to clarify the chief complaint. Just know that the initial chief complaint here in your scene size up can be again wildly different from the actual chief complaint. This can happen due to misinformation, misinterpretation, or exclusion of information. The key here with this first chief complaint is that we don't want to start pre-treating your patient before you actually assess them. Make sure that this chief complaint does not lead your decision or have you go down a treatment path that's not actually accurate. So for example, I've been called in the past for the chief complaint being chest pain, where in actuality the patient had anxiety disorders that was creating hyperventilation, creating some chest pain, numbness, tingling, etc. I've also had it the opposite direction where they thought it was anxiety or stress related response and it turned out to be a cardiac event. So we just don't want to see folks pre-treating your patient and just blindly going down one individual road without doing a thorough assessment first. Okay, so our next step is our MOI or our NOI. MOI means mechanism of injury, and this is typically used for an injury, fall, MVC, and we often see this in our trauma assessments. NOI is nature of illness, typically used for sickness, cardiac, respiratory, and we typically use this one for our medical scenarios. This is our last step in our scene size up, and it is to try and determine the cause of the patient's problem. So we know their chief complaint vaguely. Now we need to find out how this all kind of happened. You could actually have an MOI and an NOI at the same time, depending on the situation that you're responding to. And that's why I actually prefer an integrated medical and trauma scenario, preferably to just teaching based on just medical or just trauma. We need to be educated, in my personal opinion, in the fact that if you see a trauma patient, your priorities just change, but we don't neglect the medical issues that could potentially be there as well. And as you move up in your education and training, we notice that it starts off as very separate, medical versus trauma. And as we go up in that education, training, understanding, and experience, we see that they tend to end up merging together more often than not. So hopefully that will help a little bit. Okay, so our first initial little box in our scenario is about our scene size up. And in our scene size up, we talked about today hazards, including but not limited to fire, wire, gas, glass, traffic, people, drugs, and otherwise. We talked about BSI and PPE, how we should always apply that before we respond to any situation. The importance of time, date, and weather. Is it hot, cold, wet, dry, dark, light? How many patients we have, and do we need triage, and do we need help? Our backup and support that we might need, whether that's police, ALS, BLS, fixed wing, rotor wing, things of that nature. We also talked about our bystander information and if they can help out or not, our chief complaint and what it represents. And then lastly, we talked about our MOI and our NOI in regards to our mechanism of injury or our nature of illness. So that concludes that. Okay, so that concludes our lesson for the day. Thank you, and we appreciate the time you've committed to your education. We would love to hear from you, so give us your feedback, put a comment down below, send us an email. If there's a certain topic you'd like us to discuss in the future, we'd love to know about it.